Good afternoon, sir. Good afternoon, everyone. Thank you very much, sir, for the kind introduction, and thank you also for inviting me to give this presentation. So this afternoon, I'll be talking about. Can you see my screen, my slides, please?
Yes, we can.
Okay.
Yes, we can.
Okay, thank you. As already introduced, my name is Tolulope Bella-Awusah. I'm a senior lecturer at the Department of Psychiatry, College of Medicine, University of Ibadan. I'm also the acting director of the Center for Child and Adolescent Mental Health and a child and adolescent psychiatrist at the University College Hospital. So I'm really happy to be here today to talk about this topic, community child mental health care in low and middle income countries. So this is the outline that I'll be following. I would like to start with definitions of child and adolescent mental health, just a brief definition. And then from there, we'll talk a bit, just looking at the background, the need for community child and adolescent mental health care services in low and middle income countries. Basically, I'm going to be using sub-Saharan Africa as a prototype of low and middle income countries. As we know, I think basically almost all the countries basically all sub-Saharan Africa are low and middle income countries. So a lot of what I'll be presenting will be from there. And then we'll talk a little bit about barriers to community child and adolescent mental health care in low and middle income countries, especially in sub-Saharan Africa. And then we'll end with opportunities and tools that we can use to drive community camp care. So just as a brief definition, as I said earlier, what is child and adolescent mental health? We can define child and adolescent mental health as optimal psychological development, where a child learns to have a positive sense of self, they learn to like who they are, they're able to manage their own thoughts, their emotions, and relationships. They're able to learn and acquire an education, and they have this opportunity to fully participate in society. And I always like to think, well, I got this example from a friend, a very good friend, but I usually use it in most of my lectures, that we can think of mental health, child mental health in a cup, where the aim is to have that cup overflowing, to have it full and overflowing. But of course, different people at different times, different children at different times have it, some will have half full, some 3/4 full, some maybe 1/4 full. So as we know that mental health is on a spectrum, but the ultimate aim is for each child to enjoy that optimal psychological function, which is overflowing.
I think she has issues with her network. Let's just be patient, she will be back.
So the issue of sharing slides and presenting, sometimes it overloads network.
She's back.
Hello.
Hello, welcome back.
Okay, sorry about that. I think the internet in Ibadan is really, really bad today. So, but I will just try our best. So I was saying that, so why is there a need to focus on children and adolescents? And these are some of the reasons that they constitute a third of the world's population. And about 90% of them live in low and middle income countries, like many of our countries of sub-Saharan Africa, where they form up to about 50% of the population. And for example, in Nigeria, children and adolescents below the age of 18 are about 52.8% of the population. So really, we cannot talk about mental health without talking about children and adolescents, because especially for us in low and middle income countries, they form such a huge part of our population, and we need to address their mental health issues. And so this is just a diagram, a figure that looks at population of children and adolescents across the world. And if we look at this, we can see that this is so from about 1950 to about projections to about 2100. As here we can see that we're at about 2020, 2021, and we can see that in Asia, the population of children is about 40-something%, and in Africa, also the same. If you compare to the rest of the world, where it's basically a straight line that they have. So most of the young people of the world are in the low and middle income countries of Africa and Asia, and we really need to attend to their mental well-being. So now going to the burden of mental health problems in children and adolescents, because of course, if we want to provide community mental health services, we have to know who is affected, what kind of problems are there, how many children are affected. This is so important, for us to know before we can really talk about designing community mental health programs for children. And so, as I'm sure most of us know, unfortunately, in many of our countries, we have very little research that are community-based. As I'm sure a lot of us know, most of our research are hospital-based, clinic-based, school-based. So really, real community data is lacking in many low and middle income countries, and especially in sub-Saharan Africa. But we have a few, so I'm just going to share some of the statistics that we have. I think the first community study in sub-Saharan Africa was in Sudan in 1965, which looked at mental health problems among children and adolescents. And that study found that about 8%, excuse me, about 8% had behavior problems as reported by their mothers. And then there was another study in Nigeria. This was among 440 children, Nigerian children aged between 5 to 16. This was in 1990. And this found the frequency of severe behavior disorders to be about 16%. And this is very close to the statistics that we have from all over the world, which is about 1 in 5. About 1 in 5 children have a serious mental disorder at some point in their lives. And we also know other statistics tell us that about 50% will have their first their first episode by age 14, and about 75 by about age 24. So really, we can see that it's very important that we attend to the mental well-being of children of this age group. And then this is just looking at some of the average age of presentation of some of the children presenting with different disorders. So we have attachment disorders usually presents, although from my own little experience, we don't see many of these children. So, but these are more global statistics. So for the average age of presentation, about between 0 to 3 years old. And then for the pervasive developmental disorders like autism, like intellectual disability, children often present between the ages of 0 and 6 years old. For children with disruptive behavior disorders, so things like conduct disorder, ADHD, children often present from about age 3 upwards. And then for children presenting with mood and anxiety disorders, they often present from about age 6 upwards. Substance use disorders usually is more of a disorder of adolescents. So average age of presentation of children is from about 11, 12 upwards. And then adult type psychosis, children and adolescents often present with this from about age 14, upwards. So just giving us an idea of the different disorders, the kinds of the ages at which they present. And I've also looked at some of the they will also be looking at some of the how common are some of these disorders. So as I said earlier, there's little data, but based on the little data that we have, there's some studies have shown that intellectual disabilities the prevalence is about 2 to 3%. This is from but it says here recent meta-analysis, not so recent because that was in 2011. But generally, that this is higher than the global average of about 1%. And this is not surprising because, of course, we know that in many low and middle income countries in sub-Saharan Africa, we have high rates of obstetric complications, neonatal infections, epilepsy, and of course, this increases the chances of children having intellectual disabilities. And then for disorders like ADHD, so this is looking at several countries. So the ranges that are reported are between 1.5% to about 1.5% in Ethiopia to about 8.7% in Nigeria. Other neurodevelopmental disorders like autism, so we have ranges from about 0.8% to about 2.9%. Although I think these were also not, these were a hospital-based and school study. So as I said earlier, we really don't have those community statistics. And then for anxiety disorders, these range from about 1% among primary school children in Ghana to about 26% in rural Uganda. And I think that area was an area where there was a lot of conflict. So it's not surprising that those children had very high rates of anxiety. Depression, I think we have more community-based studies on depression, and ranges, prevalences range between 1.5% in Ghana and Ethiopia to about 20% in Nigeria. And then for suicidal behavior, we have ranges from, but this also is something that is not much studied. And we know it occurs in young people, but it's not very much studied. We have prevalence rates of about 23% for suicidal ideation. So that's about 1 in 5 young people, having recurrent thoughts of suicide, and about 12% for previous attempts, those who had actually attempted to commit suicide. And it was found out in this study, that adolescents living in urban areas, those who were from polygamous families, and those who were from broken homes had much higher rates of suicide than their counterparts. Other disorders like conduct disorder range from about 2% in Ghana to about 12.5% in Kenya. Substance abuse also range from about 21% in Nigeria to about 48% in Ethiopia. So you can see very large ranges there, and so it's also something that is very common. And substance use disorders were much higher among street children, with prevalence rates of over 60% among street children. So apart from the burden of mental health disorders, there are also a lot of psychosocial issues which often occur in children in low and middle income countries, like children living in sub-Saharan Africa. So they're not mental disorders, but they are issues, psychosocial issues, which increase the risks of children and adolescents coming down with mental disorders. And these are things like child marriage, girl marriage. So there's some statistics that tell us about 40% of girl children in this region are married by the age of 18. And of course, we know what the risks that predisposes them to anxiety, depression, PTSD, and the obstetric risks also. So, and then also the problem of child laborers, working children on the continent. We really don't have precise statistics, but the one I found estimates that there are 50 million, child laborers on the continent, about 10 million street children. These statistics are a bit old, so I'm sure the numbers are even much more, currently. About 120,000 child soldiers in sub-Saharan Africa. This is estimated to be about a third of the world's child soldiers. So in sub-Saharan Africa alone, we have a third of the world's child soldiers who are involved in various forms of conflict all over the continent, and over 1 million child sex slaves. Other psychosocial issues include things like poverty. We know that children and adolescents, when families are poor, children and adolescents are the most hit. So children and adolescents make up nearly half of the population living on less than $1.9 a day, which I think is described as extreme poverty. Lots of children also having poor quality education, lots of out-of-school children. I think Nigeria alone had over 10 million out-of-school children. So being in school, being in some form of educational system gives a lot of protection to children's mental well-being. So when children are out of school, they're on the streets, they're more likely to be abused. So all these issues, all the psychosocial issues make it harder for children in this context to enjoy good mental health. We also have the problem of children living with HIV/AIDS. We have the problems of children who are orphaned. We estimate that there are over 50 million orphans on the subcontinent, and about 30% of children on the subcontinent are living in areas of conflict. So, this is something we see also in our own country. Many areas of the north that have been ravaged by conflict, where children are displaced, they're out of school, their families are poor. So all these circumstances make children more vulnerable, and this is all the more reason why we need community mental health services for children. At current trends, it's been estimated that about 9 out of 10 of the world's children living in extreme poverty will be living in sub-Saharan Africa by the year 2030, which used to look like, it's many years away, but right now it's just around the corner. And when we look at school enrollment, so this is by geographical zone, so comparing sub-Saharan Africa, South Asia, Middle East and North Africa and other regions of the world, we can see that our school enrollment rates are so much lower. So the blue line is for primary school enrollment rates. So the first block is sub-Saharan Africa. And if we compare that with all the other regions, we can see that all our enrollment rates are so much lower. So whether it's primary school, lower secondary school, or upper secondary school, so fewer children are being enrolled, children are finishing. And of course, this has serious implications on children and adolescents' mental well-being. Those who are in school are also not getting good quality education. And when I first saw the statistics, it was quite shocking to me that it's been estimated that about 38% of children in this sub-region leave primary school without learning how to read, write, or do simple arithmetic. So even though they are able to access school, but they are not, it's like they're not gaining anything. They can't read, they can't write, they can't do arithmetic. So how can they enjoy, how can they compete for good jobs? How can they enjoy good mental well-being? So all these are a lot of those psychosocial factors that make it harder for children to enjoy good mental well-being. So going to the barriers to community child and adolescent mental health. So this is just this is from a study that was done. It's an old study, but I don't think there's been any updated study. So this was done in 2010, which looks at policies and legislation. So this looks in Ghana, South Africa, Uganda, and Zambia. So Nigeria is not even here. It's not even there. But of course, these are all low. We are all low and middle income countries. So I thought we could use them, also as a prototype. So as we know, many of our countries don't have updated mental health policies, plans, or legislation. But looking particularly at the third column where we have the child and adolescent mental health policy. So Ghana doesn't have, Uganda doesn't have, Nigeria doesn't have, Zambia doesn't have, and South Africa had one which was made in 2002. So really, how do we drive child and adolescent mental health care, where we don't have the policies, we don't have the legislation, we don't have the plans, we don't have the funding. These are some of the problems that make it more difficult to actually provide services, for our young people. Also looking at the different kinds of services in this country. So, so this table looks at number of outpatient clinics, and then it looks at percentage for child and adolescent mental health. So, for example, in Ghana there was 0, in South Africa 1.4, in Uganda 0. Okay, so the one in red is a personal communication, like about 2%. These things actually come in the paper. So these are some of the problems that we just don't have the resources. We don't have the clinics. There are very few resources for children and adolescents. We know that child and adolescent mental health as a subspecialty is just developing, so, and a lot of focus is still on hospital-based services, so like inpatient services, outpatient services, and sometimes long-stay services. But even when we look at this table, you can see that even there, the percentage of beds in general hospitals, in mental hospitals, is very, very small. The percentage for child and adolescent mental health is very, very small. Day treatment facilities, which are like community services where children just go in and they go in for the day, and then they can go back home, also very, very small in this particular situational analysis that was done. I mean, it's quite old now, but it's still one of the most recent that we have. And then mental health professionals in schools. The schools are a community setting where children's mental health can be addressed. So if we look at this in these 4 countries also, so we have 0, unknown, 0, 0. So just to show that there's still a lot of work to be done in terms of developing services within the community for our young children. So other barriers to community child mental health services is that there's little being done in terms of primary healthcare services. So we know a lot of primary healthcare providers are not trained in child and adolescent mental health. So they see children, but many times they can't pick up child mental health problems in these children. We have a shortage of child mental health professionals in most low and middle income countries. And another way we could, there's also few links with other child sectors, so other places where children are being either educated, are being cared for, that we still don't have strong links with a lot of these other child sectors where we can build, so that we can build up child mental health services. In a study of 42 low and middle income countries, it was found that only about 63% had a few schools which were providing child and adolescent mental health services, and only 1% of those schools had one or more mental health professional on their staff. So just showing some of the issues. And of course, when it comes to research, monitoring and research is something I had already mentioned earlier also, that we really have little. I mean, of course, more and more is being done, but there's still a lot to be done. So coming out to the international norms and standards for child and adolescent mental health care, it's been stipulated internationally that child mental health care should actually be done in community settings, in primary healthcare settings. This is an international norm all over the world. So I think the operative word is in the least restrictive setting. So children should be cared for within their families, within their communities, where they have their natural support. And a lot of research has been done in high-income countries showing that children do best when they receive care in this setting, in their homes, in their schools, in community settings, rather than being put in restrictive settings where they're separated from their families and their friends and their communities. And it's also very important that there has to be a continuum of services, so they may need educational services, they may need welfare services, social services. So as much as possible, children's mental health care should also be in places where they can have this continuum of services. So it's so that they don't have to, it's easier to just have all the services in one place rather than they have to go to different places. And we know that many times children cannot access services on their own. They depend on families, parents, guardians, teachers, to be able to access services. So it can be so much more difficult when one has to access these services in different places. So there should be this continuum, community settings where you can have all the different services that a child might need. And especially for children and adolescents, there has to be a balance between prevention, promotion, early identification, treatment, and rehabilitation. And we know that for children, one can do a lot in terms of promotion, in terms of prevention in a lot of these community settings. So we're not only looking at treatment and rehabilitation, but also what can be done, to improve children's mental well-being in their homes, in their schools, with their parents, with their teachers, and all that. Excuse me. And then the priorities of the children who are most at risk should also, the problems of children who are most at risk based on a lot of the psychosocial issues that I have talked about should also be given priority. So this is just to show the core values of systems of care for children and adolescents. And one of the very strong core values is that it must be community-based. So I'm sure a lot of people listening are probably developing services for children. So one very core value of developing services for children and adolescents that it has to be community-based. There's a lot of evidence from high-income countries showing that children do best when they're in their natural environment. And we must not take them out of their natural environment to provide care. And we have to provide care which is promotive, preventive, identifies early, helps them, treats and helps them to recover and be able to continue with their lives. Other core values is it should be family driven. So we as child mental health professionals, we need to work closely with families. So we in a partnership, working with families, so looking at the needs of the families in terms of different things, culture, their religion, their preferences, all these things have to be brought into the mental health care of children and adolescents. And as much as possible, it should be family and child-centered. So just to summarize again, the barriers, which was more or less covered to community child and adolescent mental health care. One of these I had said earlier, the extent of the burden is not really known. Yes, we're having more and more research being done, but there's still a lot to be done. Policymakers are unaware of the burden and the loss to the nation, that when children do not cannot enjoy good mental well-being, they cannot thrive, they cannot reach their potentials, and they cannot give back to their society. So a lot that connection is still lost. It's still not. People, our policymakers are still not fully aware of this. Of course, we know about the political instability in our country, so and not just our country, but in many of the low and middle income countries. So even when there are policies and plans, implementation, monitoring, all these things become a problem. I talked earlier about the poor training of health professionals in child mental health. So most of people working with children are not do not have proper training in child mental health. So many children come to them, but they do not pick up, because many children who have physical problems also have psychological problems. But these problems are not being picked up, especially because a lot of children who present with mental health symptoms will present with somatic symptoms. So they won't come and say, I'm sad or I'm anxious. Many will have headaches, have stomach aches. So a lot of somatic presentations these are being missed when children present to health professionals. Another issue is that children who are very much in need are hard to reach. So many of them are in areas of conflict. Some of them are in rural areas. As we know, in many of our countries, most of the services, or if you can say all of the services we have, are in urban settings. So children in rural settings, in areas of conflict, nobody, they get forgotten. Children with disabilities, who are also very much at risk. A lot of the children, are forgotten, are locked up at home. They're locked up in the village. They're locked up in rural areas, and so we are not able to reach them. And so we're just reaching a few of the ones who may not even have the more serious issues. Of course, also there's the impact of stigma. And focus on traditional beliefs of causation and care. So as we know, in many of our societies, we believe that child mental health problems are punishments for sins, they're generational causes, they're spiritual attacks, and so many families would rather seek spiritual help than come to the hospital, or seek healthcare providers, seek care from healthcare providers. So all this also makes it difficult, makes the work of providing services in the community difficult because of these beliefs. Okay, so despite all these difficulties and all these barriers, there are also a lot of opportunities to develop community child mental health services in low and middle income countries. I had said earlier that many of our countries do not have policies, we don't have the necessary legislation, we don't have the necessary policies, we don't have the political will. But at the same time, there are some tools we can use to drive child and adolescent mental health care in low and middle income countries. And in particular, I have these three. So one is the Mental Health Action Plan, the WHO Mental Health Action Plan, although of course this was from 2013 to 2020, but I believe it's still relevant. Another is the 2030 Agenda for Sustainable Development, and a third is the United Nations Convention on the Rights of the Child. So these are documents, which most countries, low and middle income countries, have adopted. They're committed to, they're working towards, and a lot of all these tools have relevance. They have relevance to child and adolescent mental health care. So for example, the Sustainable Development Agenda, as we all know, this is a plan of action which was adopted in 2015 and focused on, the 5 Ps, so ending poverty and hunger for all people, protecting the planet, ensuring prosperity, fostering peaceful societies, and revitalize global partnership for sustainable development. There's 17 goals in all, but quite a number, about 7, have direct links to child and adolescent mental health. So just to give an example of some of them. So for example, goal 2, which talks about zero hunger. And this goal has specific targets to enable infants to access safe, nutritious, and sufficient food. And this will help to reduce the incidence of intellectual disability, help to enhance cognitive performance for your infants, children, and adolescents, and ensure future productivity. So all countries working towards these goals, it has a direct link with the mental health of our children and adolescents. Goal 3, for example, is good health and well-being. And one of the targets is to ensure healthy lives and promote well-being for all at all ages. This also has strong targets for mental health and child and adolescent mental health. It includes prevention and treatment of mental disorders, includes promotion of mental health and well-being, and tackling substance abuse. Another goal which talks about quality education. So one of the top targets is to ensure inclusive and equitable quality education and promote lifelong learning opportunities for all. So this looks at quality and supportive learning environments from early childhood. So as countries are working towards ensuring these goals, at meeting these targets, it has direct consequences for ensuring that children, they can be in school, they can learn, they can have all the protection that being in school offers to their mental well-being. And the Convention on the Rights of the Child. So this is a human rights treaty which was formally concluded and ratified between states. I think that was in 1990, and it's been ratified by almost all countries of the world. And out of the 41 articles in Part 1, over 60% have direct implications for development of mental health services, research and training for child and adolescent mental health care within countries. So it talks about right to life, right to protection, so many rights, right to freedom of speech, so many rights, but all this can be linked to developing child and adolescent mental health care for our young children and adolescents. Other opportunities for community camp care is development of services. As I said, in many places, this child and adolescent mental health services are just developing. So having the right frame, having the right frame of mind, that we need to see how we can develop more community mental health services rather than hospital-based mental health services. As we work towards developing these services, we can actually focus, put a focus on developing community care for children and adolescents. By one could be by linking with other sectors, so we know that other child sectors where children are cared for. So for example, education, so developing services in schools. We know this is a natural environment for children. Children are supposed to go to school. It's one of their rights to have an education. So seeing how one can build up, school mental health programs. Nigeria, for example, Nigeria and I think quite a number of countries have school health programs. But if we look at a lot of those, they have policies and some have programs. And if we look at a lot of those policies, there's a huge gap in the mental health component. And so this is something that as we continue to advocate and to develop services, for young people, the educational settings are a huge place, where children and adolescents' mental health can be addressed. Of course, as I said earlier, a lot of children don't go to school, so just developing mental health services will not be enough. But as things continue to work towards getting more children in school, at least those children who are in school can be helped if there are viable programs and viable policies to address their mental well-being in school. Another sector is the juvenile justice sector. We're talking about street children. A lot of children are abandoned and neglected, apart from their parents, end up in the juvenile justice system. And I'm just talking about our own little experience in Ibadan. We have links with the juvenile justice system, with the courts and with the remand homes. And you see that there's the people who work there know very little about protecting children's mental health, promoting prevention, know very little about treatment. So these are all opportunities. Developing links, with these different sectors can help us to really be able to set up services that can address children's well-being within the community. Also child welfare services. A lot of children also come into contact. The juvenile justice and the child welfare are usually linked. So some children are still with their parents, but somehow they get to the child welfare services. So these are all links that we can make so that we can actually provide services for children within these other sectors. Just talking a bit about school health and well-being. I think I've talked about it, but as I said earlier, that schools are a natural environment for children. All children are supposed to be in school. We know that's not the reality, but we continue to work towards it that all children attend school. But the thing also is that it's not just attending is not just enough. Children spend hours and years in school. So it's a perfect place to have programs that promote their well-being, which will be through training of the people who care for them, in mental health, how to deal with them, how to identify children who may have problems, how to carry out simple interventions, you know, how to make the school a healthy place where children can come to, where they can be happy, where they can grow, where they can achieve their potential. So on average, children spend about 8 hours. These days, at least in our own country, children spend a lot more hours. Some spend up to 10, 12 hours in school. So it's a lot of, gives us a lot of opportunity, putting the right systems in place to be able to intervene and to provide promotive, preventive, and treatment facilities for young children. Excuse me, okay, I think I've said all this. Okay, another very important opportunity is integration of mental health into primary healthcare services and pediatric services. So this is in the health, coming back to our own health sector now. In that, excuse me, we know children are able to access primary healthcare services, primary healthcare services in most communities, in most low and middle income countries. As I said earlier, many people are not trained, but now we have this the MH gap manual, you know, so there's a lot more being done to integrate mental health into the primary healthcare services, and the care of children, the mental health care of children is also there's some modules in the MH gap which also talks about children, you know, dealing with families, dealing with children. So a proper integration, you know, of into this primary healthcare services will go a long way into improving community child and adolescent mental health care. And then pediatric services, we have pediatric services all over the place, public, private, you know, and usually they're the first port of call, you know, for a lot of children. They come there, they see the pediatricians, they see the general physicians, they see the pediatricians, you know, and so we also have to develop these links, you know, with these pediatric services, public and private, so that with training, with, you know, sometimes, you know, collaborations together. Just to give an example, like something we have here in Ibadan, we have a joint clinic with one of the pediatric units, pediatric neurology. So we have this joint clinic once a week where we see patients together. We found that over the years, this has helped a lot in terms of their being able to identify, being able to refer to us, you know, even their own knowledge of mental health has improved, you know, over the year. So it's a great opportunity working with our colleagues and, you know, also helping us to demystify some of these issues. When we work side by side with our colleagues, you know, we can actually help them, you know, to be able to identify better, to you know, be able to treat and to know when to refer, and then if they come for more intense treatment, also we can refer them back and they can continue their management in a lot of these services. Other opportunities for community camp care are things like task shifting. I said earlier, we will I'm sure. I'm not sure if I've said it, but I'm sure it will be said sometime during these 2 days, you know, that there will never be enough, you know, child psychiatrists, or ever be enough psychiatrists, you know, for everyone, especially in low and middle income countries. So that's mental health care has to be shifted, you know, to others, and that's part of what we do in terms of collaborating with other sectors. So working with the health sector, with the education sector, with the social services, the juvenile justice sector. So, you know, getting others on board, giving them, building up capacity so that people are equipped. All these other resource persons, all these other professionals are well equipped to be able to take on this task, of course, working in collaboration with us. And of course, monitoring and research, doing that. We all need to do more research, so to really know what works, you know. Of course, getting evidence from other places, high-income countries, but it's not necessary that what works for them is going to work for us. So we need to develop our own research, our own local research, looking at what models work for us, you know, evaluating the models that we have in place, what is effective, what is not, so that we can continue to improve what we do and really to provide effective care to children, adolescents, and their families. And just in talking about training and research, I just thought to talk a bit about the CICAM, but the Center for Child and Adolescent Mental Health, which is a center of excellence, which we have here at the University of Ibadan, which was basically started with the support of the John D. and Catherine T. MacArthur Foundation, with Professor Olayinka Olugbodo as the principal investigator and the pioneer director. So basically, this center was to train professionals in child and adolescent mental health care. And so the aim is they're building child and adolescent mental health care capacity in sub-Saharan Africa. So training, so we over the years, we've had people from diverse disciplines, you know, arts, social sciences, medical related, or not so medical related, you know, but so basically we have this program. We have the master's program, we have an academic master's, a professional master's, and a postgraduate diploma program. And we also have a lot of other courses, short courses, where people can come and train. And over the years, we've been able to build up capacity in child and adolescent mental health through this program. And so building through training and research. And basically in about the last 7 years, we've had about 130 professionals trained from 14 countries in sub-Saharan Africa, who can now go back, who have now gone back to their countries and are beginning to develop services, to train others, to conduct research, to do advocacy. Because in what we're doing, also there's a need for a lot of our advocacy. This is just showing the reach of the program in the last couple of years. So you can see the West African sub-region and the East African sub-region have people who have been trained in child and adolescent mental health. I know that many centers are also doing a lot of fantastic work training and building up capacity for child and adolescent and mental health. So other opportunities for community child and adolescent mental health in low and middle income countries. We also have advocacy groups in Africa, and there are many, but I just thought to talk about these two. There are associations of child and adolescent mental health professionals. So there's the African Association, also known as ACAM, and that's the website for anybody who wants to know more. So it's an association basically that brings about people working in the area of child and adolescent mental health, or anything to do with children. You know, people who are working with children, basically brings them together, you know, to work together, to collaborate, to do research, to advocate. These are basically what these two associations are doing. And there's also the Association of Child and Adolescent Mental Health Professionals in Nigeria, ACAPAN. That's also the website for those who are interested to know more. So these are, as I said, basically associations bringing people together, you know, to develop these services, to train, to build capacity, to advocate, and develop services, do research. Basically, these are what these associations are doing. I'm sure there are many other private ones which I haven't mentioned here. So just to conclude, to really build up community child and adolescent mental health in low-income countries, especially now in the case of sub-Saharan Africa, we need political will, we need policy formulation, you know. But despite that, we do have some things we can work with, you know, already on ground, while we continue to formulate our own specific national child and adolescent mental health policies, which will help us. You know, so we have the policy, we have the plan, we can have, you know, specific funding for what we want to do, and we can begin to actually build up a lot of these programs and services. There has to be collaborations between the formal and informal sectors. And so we have our formal sector, but we know that a lot of child mental health care is being carried out in informal sectors. So in the religious sector, in the educational, these two are very, very important, where we have to form partnerships. And I think what has helped us, you know, in Ibadan, where I work, in this collaboration and these partnerships that we've been able to form over the years, with these informal sectors, and so helping us to build up programs and some services in a lot of these other sectors. There has to be advocacy, so that's also very important, and we need to keep to advocate through our associations, through our groups, public and private. There's need for capacity building, for training, and last but not least, there's also the need for research. And it's very important to know what works, what models work, what is working, what is not working, so that we can continue to improve the kind of care that we give to children and adolescents. Okay, so these are my references. Thank you very much for listening.